Hi, my name is Dr. Philip Wrotslavsky from the Advanced Foot and Ankle Center of San Diego, and welcome to The Fix. Today, we are honored to have joining with us Dr. Subik from New Jersey. Welcome.
Thanks for having me here.
Tell us a little bit about your practice.
So I practice right near Giant Stadium, but I'm a Cowboys fan, and we take care of them. And I have to say that between the Giants and my limb salvage, limb deformity correction practice, I have a very unique, fun environment to learn and teach.
So you have a limb deformity practice. What drew you to limb deformity and limb correction?
Working with some of the attendings from residency, I had a very unique residency. In my first year, I was on a fair amount of hand and orthoplastics and hand surgery, which taught me a lot about proper management of tissue, flaps, corrective osteotomies, and external fixation, as well as using microscope and loop magnification.
So you brought a really great case today because it encompasses a lot of just everything in deformity correction. So with your case, tell us a little bit about this patient and how the patient ended up in your office and what you saw when the patient showed up to your office.
So we'll call him Andy. Andy rolls up in my office the night before he has a planned revision TTC orthodesis. He came for an emergency second opinion. He was directed to my office by a churchgoer at his own church. And they said, you should go see Dr. Subik for another opinion. Well, when we met him, he had an open wound that probed into the bone. And we took a culture of the wound, and the wound had been present for about 12 years. He sustained a motor vehicle accident and a head-on collision in his home country of Dominican Republic. And after multiple surgeries to try to reconstruct the bone through peel-on correction and removal of hardware, the wound never fully healed. They're very complex wounds and complex bone deformities. So he unfortunately sustained the varus deformity where the bone above the medial malleolus gave way. He rotated into varus, and he had a chronic osteomyelitis with a chronic fistula. Someone in our neck of the woods performed an orthodesis on the patient and using a Hindfoot corrective fusion nail and fused them in about 35 degrees of varus.
So when a patient's in varus, that means they're primarily walking on the outside of the foot. Correct. And what happens long-term if they leave it in varus?
Unfortunately, he already had developed a small wound on that fifth metatarsal area. And over time, he probably would have developed another case of osteomyelitis in the fifth metatarsal bone.
Huh. So now you have the patient here. So describe what you saw in the office and what the foot looked like, and which you did already, but you can go into that a little bit more as well. Explain to me what we're seeing on the x-rays.
You know, when you look at the foot took my breath away. He was in such varus. He was unstable with his gait. He's 31 years old, in very good shape, and he used a 4-point cane. The cane was for balance and for offloading. He refused to use a crutch. He didn't like the look of a crutch. He was so young, and he had so many years of pain with this deformity. So when I saw him walk in, unstable, a draining fistula, I really felt for the gentleman, and I said, I think this is something we could fix. He wasn't a diabetic, and he wasn't neuropathic, so he felt every bit of pain from this deformity. So with a chronic wound, we recommended immediate admission, and it was a lot for him to take it on for one day. He did come back to us. He canceled his revision surgery, came back to us about a month later when he figured everything out. But at that point, he developed a second wound. You can see in the picture, he developed a second wound. And from that second wound, you could actually see the nail residing in his leg. So the bone had eroded around that nail. And now the bone is infected, the hardware is infected, and he's in this varus deformity.
And the x-rays, tell us what's going on with these x-rays.
What's interesting in the x-rays is, and I haven't seen it too often, but when we see it, it's usually a very complex case. There were two centers of rotation angulation that we call cora. So the centers of rotation angulation typically will have one. In his case, there was a superior one and an inferior one. And in looking at his condition, he had an osteomyelitis problem at the level of the lower cora. So we determined that that would be the best place to attack. But we first had to remove the hindfoot fusion nail, sterilize the wound, sterilize the internal canal of the bone, stabilize the entire limb within a frame, plan deformity correction on Hex-ray, and that really helped us kind of understand what the second stage nail would look like and where it would be, so we could plan an osteotomy to make sure we hit a target point within his tibia. So in using that hex ray, we're able to make a cut in the correct spot through the external fixation system, correct the hindfoot and the tibia within the frame, and then remount the canal to place then an antibiotic rod. And the whole goal for that is to induce an induced membrane within the canal and in the area of the opening wedge osteotomy.
So you're going into this case knowing where you're going to make all your cuts because you uploaded your X-ray images to the Orthofix Hex-ray system.
Correct.
And with that system, you were able to analyze the deformity, know where you need to make the cut, and know exactly where you're going to take everything out.
Correct.
You also discussed with the patient that this is going to be a planned two-stage procedure, meaning the patient understood going in, this is not a one-shot deal because you first have to clear out infection before you get a finalized leg.
Correct.
So you had the first surgery in particular, you mentioned that you're going to use external fixation. Usually when we think external fixation, it's either for acute correction or gradual correction. In this case, you chose acute. But tell us about your hardware considerations and what you were thinking with the hardware, and particularly in using the Orthofix TL Hex system, there is interchangeability with some of the other Orthofix systems.
Correct.
So tell us a little bit about how you put together your frame.
The best part about the TL Hex system is interchangeable with the other Orthofix products. So we can use the TrueLock strut with the TL Hex, and I could use my gradual or acute correction facets of the strut to either use gradual correction over a period of, say, an hour within the case, or acute correction within a couple of seconds to reduce deformity. So I can match what my preoperative template looks like.
So you're utilizing the Orthofix Hex-ray as a pre-op planning,
Correct.
and then your combination of using the TL Hex and the original struts for the intra-op,
Correct.
as you call dialing it in, if you may.
Exactly, and we're using the micro adjustments within the TrueLock struts to match what our preoperative template is based upon the Hex-ray.
Tell us what happened between the first case, the second case, and today.
So the gentleman understood he had a big problem. We admitted the patient to the hospital. He wasn't a diabetic, but he had a wound that resembled a diabetic, an open wound with infected hardware, with infected bone. So we placed an external fixator first in the patient's leg. That was the first thing we did to provide stability, because we knew we'd be pulling out a rod, and we didn't want to risk the neurovascular compromise from a twisting or a rotational deformity within the limb. Once we placed the frame, we removed the nail. We then reamed out the canal, and then we understood where the osteotomy had to be. We created the osteotomy with a low-speed burr, and then an osteotome to create somewhat of a crescentic osteotomy. With that crescentic osteotomy, we were able to actually dial in rotation, angular correction, and then translation. That was the biggest thing, to translate to correct my mechanical axis. Once the mechanical axis was corrected, then we reamed up into the tibia, and we had a nice clean canal.
Was the patient walking on this device after the surgery?
For the first 4 weeks, we kept him non-weight bearing to prevent subsidence through the tibial osteotomy. But after 4 weeks, he went from gradually evolving from non-weight bearing to toe touch, to partial weight bearing, to full weight bearing without any crutches.
When you took off the device after the second surgery, what did you find?
The most amazing thing, when we took the device off, we tested his osteotomy. His osteotomy had no rotation, no angulation, no movement, and he had full ankle joint motion. So the joint moved without the osteotomy moving at all. So we actually had a corrective osteotomy that already started ossification. So the second surgery involved us to go and re-prep the ankle joint, because part of the medial gutter wasn't fully prepped. We prepped the medial gutter, we prepped the posterior subtalar joint, and then we did another ream of the canal, not fully. We want to leave some of that induced membrane proximally, and place the Orthofix Hindfoot fusion nail across the site. The best part about the nail, if you look in the X-ray, we have one screw above the osteotomy and one screw below the osteotomy. You couldn't ask for a better placement of hardware through a system.
And that's because you prepared. How's the patient doing today?
He's fabulous. He's back as his intended goal was to return to being a barber. That's his profession. He's doing well at it. He's back in his AFO, walking, no pain, no wound, and nothing but a smile on his face.
the ability for one to be independently mobile is a gift that we sometimes take for granted.
So we go through these mantras, and the mantras that I use for limb salvage and reconstruction are to produce a stable plantar grade foot that's amenable to shoe gear and bracing and free of ulceration or infection. If I can achieve those goals, that's a successful outcome.
Wow, thank you so much for sharing that case with us today.
My pleasure. Thanks for having me.
My name is Dr. Philip Wrotslavsky, and thank you for watching The Fix.